So I've been set this rather marvellous title, Parity of Esteem, Is It Pie in the Sky? I'm going to do a very quick kind of canter across the history of parity of esteem, talk a little bit about what's going on at the moment, and then I'm going to touch particularly on the long-term plan, which obviously was published last week, and has both what I consider to be some opportunities but also some challenges for the context of the conversation that you've been having over the last day or so. And I'm going to end with a few thoughts about where I think we might be able to go in terms of how we can capture some of this agenda and take it forward in a time of great uncertainty. So let's just start with this idea of parity of esteem. It's a really weird phrase, let's face it. It sounds like a 19th century term. I can almost envisage a kind of Jane Austen novel featuring parity of esteem, where somebody's esteem was challenged, and the only way that your esteem could possibly be challenged was by a duel at dawn, or some description like that. But surprisingly, the phrase parity of esteem emerged in 2012. And it emerged first, of course, in what was the Health and Social Care Act, and the kind of context for that is important to bear in mind. And I'm not really going to dwell on the terminology. I think we can have a conversation. It may be useful for us to do that in the debate about whether parity of esteem is a helpful phrase in terms of trying to articulate what we're trying to do. The way I interpret parity of esteem is I think about the very many decades that people with mental health problems have experienced substandard services, lack of priority in terms of resources, stigma, discrimination, and so on. So if we're trying to get to a place where people with mental health problems are seen to be equal citizens in our society, then I'm all for it. If we're also trying to use this as a lever to ensure that people who experience mental health problems get an equal share of budgets and resources, then I'm also all for it. There's all kinds of different ways that we might feel that it's not the right terminology, but let's work with it. So here you are. Here is a kind of suite of mental health policy documents over the last few years. What do they all say? In a nutshell, they say greater priority needs to be given to mental health, greater priority needs to be given to resourcing, support in mental health, supporting people with mental health problems. And when you start looking at the scale of the gap, then we begin to realise the scale of the task. And so, just to kind of give a flavour of that, we do know that there are very significant challenges in terms of being able to meet people's needs, and that applies whether we're thinking about this in the context of an NHS support context, or indeed in the context of other areas of support. And I know there's a big focus in this conference on austerity and welfare, quite rightly so. At Mind, I think we spend as much time doing our campaigning work on issues around welfare and benefits as we do on NHS care, because that's what people with mental health problems tell us they want to campaign on. They want us to campaign on their behalf. And whilst there are many problems with universal credit, I do think that the kind of announcement at the back end of the week, which is a massive climb down in government terms around the transition of people who are currently receiving other benefits onto universal credit, being slowed down and tested, was the right thing to do in the face of a lot of campaigning work that we and many others did. So why should we be optimistic about this? Because you could easily argue that 6 policy documents haven't really yet made enough difference to the lives of people with mental health problems. So have we really made enough progress? Have we made enough difference yet? Well, of course we haven't. But we should be optimistic and positive, I believe. And we should be optimistic and positive because the thing that has changed is changing. Is the way that not the famous people are talking about mental health. That helps, let's be honest. When celebrities stand up and talk about this issue, when members of the royal family do the same, that helps. Much more importantly, people with their own lived experience of mental health problems are more open, more prepared to talk about their experiences, because we know that public attitudes are shifting. Not to the extent that we'd like them to, but we do know that public attitudes are shifting. And now what that now means is that in the eyes of the general public, better resource, better support for the area of mental health is seen to be a greater priority. And I've seen a number of different kind of polls which tell us that, depending on who you ask and how you ask it and so on and so forth, that broadly speaking mental health is now something like second or third in the public's priority list for investment when it comes to, in inverted commas, healthcare. So there is a growing shift in the eyes of the general public about why mental health should be resourced better. And I think those of us who care and work with people with lived experience of mental health problems have a duty to harness that increased in new interest to deliver change for the better, even in these difficult times. So I know we are operating in a complex set of paradigms here, so please accept this data as you see it. One way of measuring the gap is the levels to which people with diagnosable mental health problems get access to support. And I mean, I think this picture tells a particular story about the scale of difference in terms of the access that people are not getting, particularly. And of course, I particularly want to highlight this last bullet point in terms of the implications of people not getting the right level of help and support, particularly from people from black and minority ethnic communities. You know, the very high, very well documented, very high, greater degree of likelihood of detention under the Mental Health Act if you come from an African or African Caribbean, black or black British people kind of community. And if you've ever met anybody who has ever found themselves having to be detained, or you've ever met a member of their family, you all know what a terribly traumatic, painful, difficult experience that is. And that has to be a final resort when it comes to mental health care, not something that kind of might well happen to you because you haven't had the right access to help and support, or because it would appear you come from the wrong community. So action is really fundamentally still needed on that. There are reasons for this. Here's a set of why this is the case. You could look at a kind of model that tells us that mental health gets an unfair share of the NHS budget. We also know from kind of recent work that it's often proved difficult because of the funding structures for greater resources to actually reach the front line. We think we now at least have a much better handle on what resources are getting to front line. Colleagues like Helen at the King's Fund track this kind of data with real intensity to make sure that, and we do the same to make sure that we're able to hold the system to account, but we know it's still very difficult. And there are huge issues when it comes to workforce in mental health. And I think it might be worth us having a conversation later on today, or in the context of your discussion, about how do we put in place the right kind of workforce to support people. And I mean, we believe in a very kind of multidisciplinary kind of approach. We absolutely see the virtue, lovely to hear of peer support workers already being mentioned today, the value potentially that peer support workers bring, the value of social care and social work perspective in terms of providing help and support, the right degree of help and support to people. I knew this would happen. I've been given 5-minute warning. Right. So let's get on to I think some of the context of the discussion that you've been having today, because of course you can think about the mental health context in a kind of clinical or medical kind of prism, but as I said earlier, we find ourselves look at this mind through a kind of whole societal lens. And you know, some of these, I'm sure some of these figures you've already seen, you've already talked about in the conference. But you know, there's clearly a strong connection between poverty, poor housing, unemployment, and experiences of stigma and your mental health. And it's a complex interrelationship. It's not as simple, straightforward as simply saying, if you're experiencing, let's call it austerity, and that's a theme we'll explore later. If you're experiencing that, therefore you are going to be more likely to have a mental health problem, or indeed you're there because you have a mental health problem. It's a much more complex set of interrelationships than that. but it's one nonetheless that both at a national and a local level, we have to try to unpick and unpackage and understand, first of all, what are the, what are those relationships between these issues, and secondly, what are the appropriate ways, levels of intervention to help and support people to live the kind of life that they want to lead. So I'm not going to go through those at risk. I know slides will be available on the system later. You've also obviously had a long conversation, I know, about a focus on primary care. I think from our work, and I should at this point point out, because I'm afraid I'm not able to stay for the whole day, but my colleague Emily Waller, who's there, Emily could wave, from our policy team, who actually knows much more about the relationship between mental health and primary care than I do, is here for the day. Yes, is here for the day, so please do talk to her about some of the work that we're doing around mental health and primary care. But the kind of context around this is absolutely to recognise that there are challenges in terms of primary care availability. We obviously have to recognise the complex relationship between poor physical health and your mental health, and this increasing recognition. I was just talking to Richard about this earlier. This increasing recognition about what the GP is actually doing in that conversation, and in the conversation is often as much about social issues as it is about, in inverted commas, clinical issues. So, one for Helen to discuss with you later, I think. So quickly, the long-term plan, I'm not going to go into this in great detail. I do think it's worth a read. I think it's worth a read for a number of reasons in the context of this agenda. I mean, I think partly because it sets out a route map for where the NHS is going to go, both in terms of mental health, but also, of course, more broadly. There are some very clear resourcing implications with an increase in investment for mental health services over the next 4 to 5 years. Some clear areas where that investment will be focused, both in community and in crisis care and in children and young people's support. I think there's a particularly important issue in the context of the proposal to reshape, if you like, community mental health services. And I don't think community mental health services have actually been reshaped for about 30 years, if possibly ever. And it would be, I think this is a really important opportunity for us to take the learning from what we see on a day-to-day basis of the way in which people who are living in community with a mental health problem, the help and support they need has to be multidisciplinary. Has to recognise that you've got to put the individual in the heart of that conversation and not systematise it. And I think the community and mental health and primary and community mental health kind of community is absolutely up for thinking differently about how those services and those models are developed. And I think there will be an important need for further research to really help shape what those new models, new approaches could look like, particularly when we're thinking about working in more deprived areas. One of my slides has gone, which is good news for you, but there is a slide missing on which actually pulls out some of the other parts of the NHS long-term plan. What it says, now 1 minute. So particularly, people have mentioned social prescribing. That's on the agenda for the long-term plan. Thinking about the health and well-being of the NHS staff, hugely important. Issues like social cessation also on the agenda. However, I think most importantly, we and you all know that if we simply put the responsibility for mental health into the hands of the NHS, then we are not going to achieve what we and the people we work with want from the government, from the public sector, from our society. And so our kind of strong rallying cry for the next few months will be that if we're going to have a long-term plan for the NHS, which has a clear roadmap for mental health, we need a cross-governmental plan for mental health as well that matches that. So as the 5-year full review ceases to exist for mental health, we now need a parallel long-term plan for people supporting people with mental health problems.